Hello everyone, welcome to my YouTube channel Lighting the Knowledge Candle. Today we will be discussing about the types of bias and study errors and confounding versus effect modification. This confounding versus effect modification are so important that there were many previous year questions in the INISET. Okay, let's discuss about the types of bias and with examples and the strategies to reduce that particular bias. The first bias we are discussing about is selection bias. Selection bias. Definition of selection bias is non-random sampling or treatment allocation of subjects such that study population is not representative of target population. Most commonly, a sampling bias. Convenience sampling, that is patients are enrolled on the basis of ease of contact, that is it would be easy for the analyzer or examiner or the person who is doing experiment, it would be easy for him to get information from the hospitals, but this would lead to a selection bias, that is Bergson bias or bedside bias, because a person who is admitted in the hospitals have different exposures, they have less healthy exposures. It's highly chance there would be high chance that the exposures would be different in the person who is admitted in the hospital, which is known as Bergson bias or bedside bias. That is, examples of selection bias are Bergson bias and attrition bias. Bergson bias, cases or controls selected from hospitals are less healthy and they have different exposures. Attrition bias, it is also one of the selection bias. Participants lost to follow up have a different prognosis than those who complete the study. The strategies to reduce the selection bias include randomization and ensure the choice of right comparison group or reference group. Ensure the choice of right comparison group or reference group. This is all about the selection bias. The next study bias is recall bias. Awareness of disorder alters recall by subjects. That is common in retrospective studies. If the subject knows that smoking is associated with lung cancer, then it would be highly possible that in his recall he might add smoking, which is known as recall bias. Or sometimes the people might have forgotten because of the long time gap between the exposure and disease occurrence. Examples of the recall bias include, we can discuss with an example like patients with disease recall exposure after learning of similar cases. That is, they feel that they had exposure when they know that that particular exposure is associated with the disease. Decrease time from, in order to reduce the recall bias, we have to decrease the time from exposure to follow up. From the time exposure to follow up, the time gap should be reduced so that there would be no memory issues. Use medical records as resources in order to reduce recall bias. The next bias we will be studying is measurement bias. Information is gathered in a systemically distorted manner. That is, using a faulty automatic sphygmomanometer. We know that the sphygmomanometer is faulty, but still we use it, which will result in measurement bias. The Hawthorne effect is also one of the measurement bias. What is Hawthorne effect? It is important to remember what is Hawthorne effect. Participants change behavior upon awareness of being observed. When they know that they are being observed, their particular behavior changes, which is known as Hawthorne effect, which will result in measurement bias. The strategies to reduce the measurement bias include use objective, standardized, and previously tested methods of data collection that are planned ahead of time, which were previously successful methods. In order for the data collection, previously successful methods usage will actually reduce the measurement bias, and using of placebo group also reduces the measurement bias. Procedure bias. Subjects in different groups are not treated the same. That is, we select different groups, but few people with a like, for example, for the particular when certain group of people are diagnosed with a particular disease, they would be receiving treatment from the highly specialized unit, which will result in procedure bias. Procedure bias. In order to reduce the procedure bias, we are supposed to do blinding. Observer expectancy bias. Observer expectancy bias, for example, the researcher's belief in the efficacy of a treatment. That is, if a researcher believes that the drug that is being given is efficacious in treating that particular disease, the output would be in favor of that, which actually changes the actual result. In order to reduce the observer expectancy bias, again blinding. Using the placebo group will actually reduce measurement bias. interpreting results. Lead time bias. Lead time bias, early detection interpreted as increased survival, but the disease course has not changed. Breast cancer diagnosed early by mammography may appear to exaggerate survival time because patients are known to have the cancer for longer. Like, for example, mammography detects the breast cancer at an early stage. But patients would be surviving for longer period as the mammography detected the early stage of the breast cancer, which will actually make the patient believe that breast cancer has a long survival rate, which is in fact not. Measure back-end survival. Adjust survival according to the severity of the disease at the time of diagnosis. Back-end survival, that is, if the particular patient has the disease, we have to reduce the lead time bias by knowing the severity of the disease at the time of diagnosis, at what stage the disease was diagnosed, which will actually reduce the lead time bias. The last bias is length time bias. Screening test detects diseases with long latency period, while those with shorter latency period become symptomatic earlier. The diseases with short latency period become earlier symptomatic, whereas screening test detects disease with long latency period. A slowly progressive cancer is more likely detected by a screening test than a rapidly progressive cancer. We must know that the screening test is one MCQ, one previous year MCQ we are supposed to know here is screening test is not useful in. They give certain cancers, but the answer is testicular tumor. It is that is, a slowly progressive cancer is more likely detected by a screening test than a rapidly progressive cancer. If the particular cancer is rapidly progressive, it highly unlikely that it is detected by a screening test. In order to reduce the length time bias, a randomized control trial assigning subjects to the screening program or to no screening is to be done in order to reduce the length time bias. The next thing we will be discussing is about confounding versus effect modification. When a factor is related to both exposure and outcome but not on causal path, distorts effect on outcome. No true association exists. In fact, when a particular factor is associated with both exposure and outcome, but there is no true association. Examples: an uncontrolled study shows association between drinking coffee and lung cancer. However, people who drink coffee may smoke more, which could not account for the association. That is, you have the coffee is associated with smoking. Smoking is associated with lung cancer. Coffee is directly not associated with lung cancer. Here, the coffee is the confounding factor as it is associated with both exposure and outcome. In order to reduce the confounding factors, crossover studies, crossover studies, matching analytic techniques such as regression analysis when confounding variables are known and were measured. In order to reduce the confounding effects, crossover studies will reduce the confounding effects, matching and analytic techniques. The next would be effect modification. There were previous year questions on effect modification. Exposure leads to different outcomes in subgroups stratified by factor. That is, in fact, there is in fact a true association exists. For example, let's discuss one previous year question here. To determine the connection between smoking and lung cancer, a study was conducted. The connection was found to be stronger in those who exercised less and weaker in those who exercised more. Exercise in this case happens to be a effect modifier. That is, according to a study among another example is a study among women using OCP showed significant risk of DVT. But when these data were stratified by smoking habits, there was a very strong association between smoking and OCP use with DVT. But there was no association between OCP and DVT risk who do not smoke. Here the smoke. In order to how to reduce the effect modification, stratified analysis. After testing for interaction between OCP and smoking, analyze risk among smokers and non-smokers. Stratified analysis which will help in reducing the effect modification. That's all about the bias and the study errors. Hello everyone.